Okay, so welcome everyone to this month's Spirituality and Health webinar. Thank you for joining us. As I've muted everyone, but during the discussion section, please feel free to unmute yourself and ask questions to Aurelia. We are so delighted to have Aurelia Anderson today speak to us on a topic that is near and dear to her heart. And so Aurelia is a native of Sacramento, California, which is about 10 miles north of where I actually grew up. So it's kind of neat that Aurelia and I have been connected here just in the past year since she attended our Spirituality and Health workshop. She serves as a licensed marriage and family therapist in Durham County and as a grief counselor at Transitions Life Care in Raleigh. Prior to working in private practice, Aurelia worked in community mental health in Person County through Freedom House Recovery Center in Roxborough, where she coordinated Person County's community mental health support program here in North Carolina. Aurelia obtained her master's in counseling from Palo Alto University and her MDiv from Duke University, and holds a dual bachelor's degree in English and psychology from Howard University. She is trained as a clinical chaplain and substance abuse counselor and currently serves as Minister of Missions at Faith Community Church in Durham, North Carolina. Her research areas of interest include the role of spirituality in grief stages, the effects of trauma and loss among adolescents in foster care, and the role of African American spirituality in mental health treatment. Her goal is to have an overall impact on both the religious and medical communities. And so Aurelia, it's my great pleasure to introduce you, and I will turn it over now to you.
Thank you so much, Dr. Koenig. And let me just say that I am appreciative of this opportunity to be able to just share some interest that I have. This presentation, everyone, is definitely an overview. It is more of a question. And excuse me if you hear a baby in the background. This is our COVID-19 work from home situations. And of course, she wakes right up when I start to talk. So just bear with me. She will be quieted in a second. But like I was saying, this is an overview of just questions, things that piqued my interest in this area. And I welcome all questions because this is not necessarily an expert presentation, but it is one full of thought and question and seeking to understand. And so the goal and the hope is that this area is furthered. So the information, the data, the advocacy is furthered. And so counseling and older adult kinship caregivers, what about me that you heard in or read in my biography would compel this topic? Well, I used to be a foster parent. When I was in California, I was a foster parent, non-kinship care, and I'll get to that in a second of what kinship care is. But I was a foster parent, so I was with an agency that I ended up then working for as a family counselor. As a foster parent, I was a foster parent to teenagers. And then as a PTA parent here in Durham County, as a PTA parent, I was able to work alongside of foster parents. And as an in-home therapist to foster parents. And many of these individuals were older adults. And in my time working as a PTA parent, I experienced kinship caregivers. So next slide, please. It takes a village to raise a child. We hear that so often. It is an African proverb that it supports community. It supports everyone being involved in the rearing and the nurturing of children. It takes a village to raise a child. But who's caring for the village is the question. Next slide, please. So what is kinship care? Kinship care is the full-time care and nurturing of a child by a relative or someone with a significant emotional connection to the child, such as a close family friend when parents are not able to provide care. That is the definition of kinship care. Next slide, please. So who is providing this care? So kinship care. Yes, it is a biological relative. So it can be an aunt, an uncle, a cousin, a grandparent. It can be we don't consider a step parent as kinship care. So it's all the relatives or the very close family friends of the biological parent of the child. And there are 4 types of kinship care. There is the informal type. The informal type is, I am Sarah, and I have a child, Brian, and I am going through a really tough time because of situation X. Situation X is not allowing me to be at full capacity to raise Brian. So therefore, I am going to ask my mother, can you please take care of Brian for me while I tend to situation X? That is an informal type of kinship care where there is no other legal agency involved in the care. The other type of care is voluntary kinship care. So the voluntary kinship care is when we know that Sarah cannot care for Brian and other authorities have gotten involved. But instead of going a legal route to provide care for Brian, Sarah has decided, I am going to ask my mother to care for Brian. And I remain, as Sarah, I remain legal custody of Brian, but the physical custody will be with my mother. Formal, another type of kinship care, is when the state agency has actually worked with the court in obtaining legal custody. And then legally, we have taken the custody away from Sarah and placed Brian with a kinship caregiver. And in this case, Brian's grandmother, Sarah's mother. And another type of kinship care is a legal guardianship kinship care. And it is when everyone, the caregivers, the legal authorities have taken place to legally place Brian in the care of Sarah's mother. So the individuals providing the care, their relatives. Why is this important? Well, most agencies, most governmental agencies, most of those who believe, who are working in the child welfare system, believes that it is better for a child to be placed in with relatives, healthy relatives, and we'll get to that in a second, but to be placed with relatives with whom the child has a connection to and is familiar with. This, what it does is it decreases the amount of trauma that the child may experience when being removed from their home and their biological family. And so understanding that reunification is always the goal. It is always the goal of authorities when removing a child, but sometimes it is not the best interest of the child. And so kinship care provides that nurturance that children need. Research shows that kinship care can reduce the trauma that children may have previously endured that have come with parental separation. Bringing the children in with relatives can provide a sense of stability, and it gives them a sense of belonging. And so when we talk about relatives and kinship care, you can go to the next slide. It is important that those who are providing the care get care themselves. Facts, here are some facts about kinship care. 32% of placements of foster care children are with relatives, kinship care. That's national data from 2019. North Carolina data, and this is where I'm located. I know that there are attendees in every state. Actually, every state has information. It is from the AFCARS, Adoption and Foster Care Analysis and Reporting System. And the 2019-2020 is the data for 2019, projecting into 2020 is up. But, and it has for every state, okay, if this is something you're interested in. Next slide, please. And so of that 32% of children living with relatives, 37% of these children are being raised by relatives ages 60 and older without their parents present. And these are from grandfamilies.org, which is an organization that works with the Children's Bureau in order to provide information. And why is this important? Why have we singled out grandparents? Well, with the opioid crisis, and opioid use and abuse has been around for a very long time, but it is considered a crisis within the last 10 to 15 years. And because of this, there are children who are being raised by kinship caregivers because of this, because their family members are battling addiction. And the overwhelming number, and so here's one statistic that I found from the Children's Bureau. This is from the United States Department of Health and Human Services in 2017. So for every child in kinship foster care, so kinship foster care is the 4 formal types that I've mentioned. So for every child in kinship foster care, there are 20 children being raised by relatives outside of the welfare system. And so that means there's a lot more. So that 37% of the children who are being raised by older adults ages 60 and over, and that age, so I'll address that age later, there are a lot more. So then the data that is being gathered, it's highly likely that there's information we don't know, and the numbers would be drastically different, okay? So because of these arrangements, the older adult caregivers, and so the ages, what I've found is that in some of the information, older adults is 55. And Dr. Koenig, you definitely can, attend to this after I'm done presenting. But older adults, in some of the information, especially from the CDC, older adults, they did in the studies, one of the studies is age 50. And I know there will be some individuals who are like, I'm not an older adult. I'm 50 and fabulous. But 50, some say 55, but in this study, it's age 60 and above for the data. But next slide, please. So why is this important? And so I will pause here and share with you a little bit more about my work. So as a chaplain at St. Joseph's, and this is, and you know, when I first attempted, like 3 times to get into the spirituality and research and health and research workshop, and it just never, the timing and distance, things just never seemed to work out. But when I first attempted, I was a chaplain at St. Joseph's Medical Center in Stockton, California. And when I reached out to Dr. Koenig, that's when he's like, oh my goodness, I did my education there, and I was a nurse there. And so it was just like, oh my goodness, St. Joseph's. So while I was at St. Joseph's, I became certified as a palliative care chaplain. And so as a palliative care chaplain, being part of the team to discuss end of life goals for our patients, that's when, and then my residency as a chaplain, before I was at the skilled nursing facility with Sutter Medical Center. And so the older adult population has always been near and dear to my heart. But so then my time there working with older adults and their unique concerns, then as I began to work in the foster care system, I would see many more older adults caring for younger children, whether it was because of a foster care placement or it was a kinship care. And so it was just very, so that always piqued my interest. And so then as a PTA president, there was this one grandmother who was taking care of her grandchild, and she did all the things. She was at every game. She was at every PTA fundraiser. She was at every educational workshop that the principal held. She was at pickup. She was at drop off, all the things. And I don't know her exact age, but I definitely know that she was over age 50. And I remember one day at church, she was at my church, and I'm new to the area. So of course there's probably people who've been in and out of my church and I just hadn't known, but I saw her one day and I was like, oh my goodness. And I prayed with her, and she just shared with me some of the concerns that she had, and she was going to court with the biological mother for the care of the child, all the things. And the stress, and I'm thinking of the stress that was on her. And she had her own health problems. Now, at the time, I did not have that type of relationship with her to inquire further about her mental well-being, and even about her, physical health, if there were any chronic diseases that she, experienced. And so, but I'm wondering who's caring for her. So next slide, please. So what is mental health? So mental health, and we have Calm app, we have betterdoctor.com, we have talk therapy, we have it seems like it's trending, right? It's the popular thing, mental health and mental well-being. No, it's not that it's a popular trending, it's that it's becoming more mainstream. Why is it becoming more mainstream? Because we started to see mainstream experiencing severe mental health breakdowns. A lot of suicides of prominent actors, actresses, preachers, clergy persons, and their suicide. And so it wasn't necessarily that it's brand new, but it became because of social media, because of the way we treat celebrity and entertainment and information. It's becoming in our face. So then when Fox News, CNN, CNBC, everyone's covering, MSNBC, everyone's covering E Entertainment, everyone's covering. And then it's like, wait a minute, why are these people committing suicide? They have all the money, they have all the fame. And so it's starting to pique more interest. So what is mental health? Mental health includes our emotional, psychological, and social well-being. It affects how we think, feel, and act. It also helps determine how we handle stress, relate to others, and to make healthy choices. So next slide, please. So who does mental health issues affect? Everyone. Why do I say everyone? It affects everyone because we don't live in a bubble. We live in community, whether we want to live in community or not. Why do I say that? Well, even if you want to isolate in your house, and even if you decide to cook your food, grow your food, you need someone for something. We are not alone. So mental health issues affect everyone. So true story. I had to take my son to get his sports physical. And of course, it's on the day that I'm doing my presentation. But, I said, let me just ask his doctor. Let me just ask. I said, I'm doing this presentation today. And even though I have the studies and I'm not going to record you and I'm not going to quote you, but let me just ask. Do you screen your older adult patients for any mental health challenges or issues? And she says, and so she says, if they have, and you can go to the next slide, please. She said, well, if they have, we're doing a study. So the clinic where I was, she said, well, we're doing a study right now on chronic disease and illness in older adults. And we give them a screening and if they have pre-existing mental health disorder diagnoses, then we'll screen them. But otherwise, no. And I was like, that's interesting. I said, don't worry, I'm always all about, people sometimes they just get weird about giving their information. I said, don't worry, this is not recorded scientific, but I'm just wondering. And I said, and it's very consistent with the studies that I've researched, that studies show. I said, you don't necessarily screen unless you're prompted to. And I said, and I wonder why that is. And we didn't get into the conversation because it wasn't my appointment, but I said, you have a population, and I'm speaking of caregivers, kinship caregivers who are older adults, and thinking of someone, even a healthy 65-year-old with a now 5-year-old. And we're not even going to see if that child was pre-exposed to trauma, but just the mere fact of being removed from their parent is traumatic enough. And so that in and of itself is let me screen a mental health screening. So 5.7 million adults age 65 and older who binge drink in the past month, or 1.5 million adults age 65 and older who use an illicit drug in the past month, according to SAMHSA. And now, suicide is the 8th leading cause among people 55 to 64 years of age, according to CDC 2020 Fast Facts. Now, again, these are just snippets of facts. And so I'm hoping to do more work, hoping you would do more work, hoping we all would do more work in this. So older adults are not immune to mental health challenges. They're not immune to substance abuse. They're not immune to psychotic breaks. They're not immune to even suicide. And this says 8th leading cause of all the causes of death, 55 to 64. So this is not just end of life patients. We tend to think that suicide in older adults is, they're at the end of their life and they just can't take it anymore. No, I have a 97-year-old grandmother in love who, if she could get up and walk, she'd be running around the church. So this 55 to 64-year-olds. So you think, okay, it's likely that within that group, I have a kinship caregiver who's caring for some children that might need a mental wellness check. Next slide, please. So, and like I said, this, I really want discussion. And so clinical implications. The need for updated data on older adults and mental health. And so the CDC, their data, their facts, that they're in childwelfare.gov. That is the portal that has information on the kinship caregivers, is dated. And these are brochures for the community. This is not, you know, they don't need EBSCOhost account to be, you know, to disseminate this information. This is information that goes to everyone. And so what's important is that it's updated. And as we have an aging population with the boomer generation, there are going to be more need for this data. Need for updated data on older adults as caregivers, the same. So it's increasing. So the numbers are showing that it's trending up of them, the number of children that are being placed in foster care and that are being placed in kinship care. Okay. The screening for mental health problems at doctor's appointments. And I know there are some physicians on this call, and hopefully they're still with us, but I don't understand the behind the scenes of and timing and insurances and all those wonderful, you know, restrictions and limitations. You know, so just knowing that there's limited time. Can we get screenings for mental health problems at the check-in doctor appointments for the physicals, the annual physicals, and not just how are you feeling, but do screenings. So there is the CDC. So they have conducted, and this is 2010. And it's called the BRFSS, the Behavioral Risk Factor Surveillance System. So it helps states survey U.S. adults regarding a wide range of health issues and behaviors that affected their health. So this is great. This is awesome. And within this, they use the PHQ-8, the anxiety and depression module. But this was a telephone surveillance system, and they prided themselves because they got a chance to do a large sample. It's proven in its reliability and validity, but it excludes people who don't have telephones, and it excludes people who are in institutions such as nursing home or facilities. And so it may underrepresent the population, because the findings showed that the majority and the majority, so you have like 80%, 90%, 95% of everybody is okay. Mentally, they're mentally healthy. They have support. But what it did show, the CDC study did show that women, Hispanics, were more likely in their age range. They did 50 to 64, and then they did 65 and older. Those two groups tended to show more of the mental health challenges and not feel as supported in their scale. And so I would definitely like to look at this one more, but screening for mental health problems at doctor's appointments. And so what the CDC did show is that the older population, they don't really talk about mental health and wellness as much as the younger population would. And I would suspect, just my own hypothetical, like my own hypothesis, is that it may be generational. it may be a cultural thing, but Dr. Koenig is saying yes. But I mean, there's I'm sure a lot of cultural implications about that. And so I would love to dig deeper into that. Research on best practices for counseling these kinship care families. And so one thing that a lot of the foster care agencies are pushing is support for kinship caregivers, all sorts of support groups, individual counseling, respite care. So they're realizing that they don't necessarily get the same benefits, like the financial benefits and a lot of the support that those that are in like legitimate foster care agencies and foster care placements that they would get. And so they recognize that, and they're doing more work in advocacy. And so, and also the survey, I would love to see a survey, participants of Medicare coverage Part B for mental health services. And there's no rhyme or reason why that piqued my interest. But when I was looking at the coverage, a question came to me was, I wonder what that looks like. I wonder if most of my clients are not older adults. Most of my clients are young adults and middle-aged families. And so I wonder what that looks like and who they go see, and if so that just interested me. So but that's my presentation, my formal presentation. Next slide, please. I think it's just references my references that I use, and Dr. Koenig definitely can email this out to everyone as notes. But like I said, this was just an overview of an interest that I have, and I'm curious if anyone has any experience with this topic, with this subject. If you have any questions for me as it pertains to my interest in this, so.
Okay, thank you, Aurelia. Let us now open it up for questions. So we will post your PDF of your slides up on our website, as well as this recording.
Okay.
And so if anybody has questions or would like to comment or to share their wisdom with regard to this subject, please unmute yourself and talk.
Hi, can you hear me?
Yes.
Yes. Hi.
Okay. Hi, I'm Erica Decker. I'm a chaplain here in Michigan, actually. And in a sense, this is at least a new way of looking at this issue. You know, one thing that really did strike me is when you were talking about like the suicide rates. And I haven't done any sort of formal kind of looking or whatever. So I appreciate you doing that. But just in my day-to-day visits, it always does kind of, I guess, surprise me, like, oh, here's a 63-year-old who, attempted suicide. And, sometimes they want to get into it with me. Sometimes they don't. And that's fine. But just, I do, I feel like often we think of suicide as like a younger person's thing, which it is, but to be, I think this focus on mental health, I mean, especially you're bringing up the opioid crisis. I mean, COVID itself has just been a huge issue. The increased awareness of, and therefore reality of, race relations in the US. I just 100% support, kind of your inclination in this way. So I guess maybe it's more of a comment than anything, but I also yeah, I do find that connection you're making between like foster care, kinship foster care, the opioid crisis, or other stressors that, you know, cause children to not be able to be with, you know, their biological family, or, you know, family of origin. Um, it's the real deal. And yeah, what can it take to do like a very quick but effective kind of mental health screening?
You said something so key, effective. That was that
Mm.
word, effective. And so even though my son is 13, it's still the screening that, you know, the questions, I had to supplement some of the questions that the doctor was asking him,
Mhm.
because it wasn't effective. And I knew that by his answer.
It
And
wasn't connecting where it needed to
it did not
connect.
connect.
Yeah.
And
Yeah.
so imagine a very sensitive topic of emotions and mental stability with, you know, a group of individuals who that may not have been their experience to talk about
Your
emotion and
training. Yeah.
emoting. So effective. So I wrote that down. I was like, oh yes, effective. What is an effective way, a brief, effective way
Mhm.
to get a whole lot of information? And guess what? Therapists, psychologists, social workers, we're trained, chaplains, we're trained to know we only have, well, therapists may not so much, but chaplains, we're trained. You have a small window. What question are you going to ask that can allow someone to share and open up, right? And so we have to know about effective questioning. But yes, and so with that, with what you were saying, so widowhood is one leading cause to mental distress in older adults. And I'm leading a spouse loss group right now, and I pretty much do it periodically with the hospice agency, Transitions Life. And widowhood, meaning widow, like men or women.
Yeah.
But and a leading cause of depression. And so who's doing the screening if they're not connected to a hospice agency or a friend of a friend who is, to know, this is not normal grieving. This is something that I need more support with. So thank you for your comment. I wrote some notes.
Thank you.
Yeah, I've got a little comment here. It's a real issue with regard to even the physical endurance of older adults who are trying to care for young children. And many of these older adults are single. And so it's, and many of them are women. So
Yes.
women, older adult, possibly multiple medical problems, and then caring for a young 3 to 5 year old that's running all over the house. You know, what a challenge to try to, just physically catch up with them if you're alone and you've got physical health problems yourself, and you don't really want to talk about it with anyone because you're afraid that maybe they'll take that child out of your home. So you're going to kind of conceal, right? Some of the emotional stresses that you're experiencing, and many people, I think, they take it to God. They try to, to deal with it by praying, by asking God for help with these things. So the chaplain seems to be an ideal person to be able to help address some of these issues. But the physical stress it can be pretty intense, I would imagine.
There's a question in the chat. It says, what are some ways folks have broached conversation with older adults about their mental health self-care in ways that seem effective? Curious to hear what language has worked well. And so for me, and I draw on, because like I said, most of my clients are not older adults. But my chaplaincy work, and working in chaplaincy for 5 years, we treated spirituality and mental health, they're cousins. right? We treat it all the same. And so I know for me, presence was more than anything. So my presence with them when I would walk into a room or make a visit with them in, wherever they were, whether it was a mental health hospital, making sure that the "how are you doing" question was never really part of my conversation. How is today? That's how I would start. How is today for you? And then leading in with whatever they're saying, that always opened up the conversation to see what's happening in their life. And then using those cues for follow-up. And so if someone talked about stress or stressors, it was always the who, what's, and when, where's to get more information and then I will always reflect back to them what they said. So it didn't come from me as the expert. It was a reflection of their own words. And what I've always found is that when someone hears their own words, they're less defensive. It's like less defense, but they're able to really reflect on what is happening inside of them. I hope that's just part of my practices, because older adults, when I walked into the room, I was always seen as someone other than the chaplain, because of, it just wasn't that assumption that I was the chaplain. I'm very tiny and I looked very young. I'm Black, female. So I was hardly ever identified as the chaplain. And then when I said, "Oh, the chaplain," "Oh, you are?" And then and usually my patients were older adults. That was always, most of the time, that was a barrier that I had to work through. So that's kind of how my effectiveness to get into those sensitive topics like mental health challenges.
Yeah, Aurelia, you're absolutely right. Opening up with an open-ended question is so important to try to get the older adult to talk. And sometimes if they don't talk, many times they will be with a relative or a friend or somebody who brings them in if they've got significant health issues. And naturally you have to have the relative in there in the room, but then you can ask the older adult, "Can I ask your friend or relative some questions?" And that's when you can ask, what have you seen? What are the challenges that Mrs. or Mr. so-and-so is now facing in their life? So sometimes you can get information from a relative if the older adult is not willing to talk about this area. But I think most older adults are, if they're given a chance, usually healthcare providers don't give them a chance to talk, but if they're given a chance with an open-ended question that is done in a kind manner, most of them will talk and share what they're going through.
Thank you, Dr. Koenig. So there was a question about how robust is the evidence that kinship care is better than other foster care where there is rigorous screening for suitability across all factors. So the Children's Bureau, which is part of the U.S. Department of Health and Human Services, so the AFCARS report is theirs. There, I will say that it's growing, but the government has really taken. I know there's lots of people who have their own thoughts about government and research and but they really have taken an interest, and they're trying to make sure that there is adequate research done. And so I'm definitely going to follow up on that. But most of them are saying that it's better, the social sciences, that it's better for children to be placed. And there is screening. So it's not just, they don't just say, oh, because you are Aunt so-and-so that you are the best person. No, there is screening. Let me see if I can find. So they assess for the strengths and needs of caregivers. And so the Child Welfare League of America recommends assessments that evaluate, and they have a list of about 10 things: the nature and quality of relationship between the kinship caregiver, the child, the parent, and other relatives, the physical, emotional, and mental health of the kinship family, the caregiver's ability to meet the child's developmental and educational needs. And so that's something that Dr. Koenig definitely mentioned because, you know, we have Grandpa James is Brian's favorite, and Grandpa James is amazing. He's everybody's Grandpa James, whether it's biological or not. But Grandpa James has situation ABC. Grandpa James, we love you, but it may not be the best placement for you and the child to have the child with you, right? So it's not just, oh, because we're a biological relative, it's about suitability. And so that is something that is very much so in the screenings, but it just shows that healthy kinship caregiver families, the children are better suited. But thank you. I will definitely look into the research on that and see how robust that it is. I know we only have like 10 minutes left. Let's see.
Yeah, there's some good questions there in the chat. One has to do with some of the children that, you know, may be incarcerated. I mean, the children of the older adult, right? And
yes,
they're dealing with that stress too.
You know, and I think that is, you know, Dr. Koenig, you always are a wealth of knowledge on how to do research best, but there's so many situations that that will remove a child from a home, and they all have different types of impact. Because, you know, if a parent dying, a parent incarcerated, a parent on drugs, while the child has been removed, so we think, oh, child removal, that's what we just need to work on, stability. There's so many nuances to those types of parental loss that must be addressed. So and our social service system is bogged down. They're overwhelmed, understaffed, underpaid. So the little things sometimes get missed. And so that's where, you know, that's just kind of where advocacy and public health and really understanding how to try our best not to miss the little details in our care, in our counseling care. So in that, my main point was increasing counseling among older adult kinship caregivers. And that is something where, and I believe in the biggest impact. So where do we get the biggest impact to these older adults? Correct me if I'm wrong. This is a guess. This is not science. Is it through healthcare? Is it through, like, who sees older adults the most that could have the impact? And my assumption is through their primary care physicians, through that system. And I don't know.
What is the role, Laura, what is the role, Aurelia, of the church in all of this? What roles does the church, clergy, other church members? Talk about that for a moment.
Okay, and so that's the other part, as you know, I'm missing that piece too as well, right? It wasn't, so that wasn't in the research, and that's a big part. So the church, the religious institutions have a high number of older adults, and so that is a component, and how I believe it's the same doctor, clergy, leader. It's the same questioning, it's the same advocacy, it's the same sensitivity, the same programming needs. And I think because it's built in, so many mainstream institutions, they have like children's ministries, and they have teen ministries, youth ministries. And so the whole family, in essence, is met when you attend a religious worship service or a religious service. If there's anyone who is Jewish or other religions, I'm not sure if it looks that way. I know in the Protestant church, I'm not sure about the Catholic church, but I know when you go to a religious service, a lot of these churches, a lot of these institutions, they'll have a nursery or a children's group of some sort. And so the whole family is being met. Older adult, they're getting their needs met. Even if it's a potluck, they're getting their needs met amongst the older adults, amongst the rest of the congregation, and the children are getting their needs met. So respite, the children are getting their needs met. But if we're not focused, thinking they need help and support as well, they'll get missed at church too.
Yeah, so the clergy need to be more aware of the issues that you're talking about, Aurelia. And,
So,
since
yes,
you're part of that
you.
community already, talking, I could see that helping to educate clergy so that they are more aware when they see an older parishioner with small children with them.
Or even teenagers.
Yeah, that's true. Oh yes, definitely.
Teenagers too. And understanding that, what used to work in my day, that may not necessarily work in today when it comes to teens and discipline. So thank you for bringing that. And like I said, I got so one-tracked because of my research that you're absolutely correct. The church, the religious institutions, they are parallel to the physicians, the medical world. And we need to make sure that anyone in leadership that serves this population, they have to be sensitive to those needs of these kinship caregivers. And yes, not the doctor's appointment, but the church, the religious institution, they are seeing all of them at the same time. So what a great way to tend to the needs of the family in an informal and formal way.
And they're seeing them like a lot of times every week, whereas
yes,
the healthcare professional may see them only once every 3, 4, 6 months even.
So there was a question about, we have like 4 minutes. There's a question about the isolation of older adults who participate in congregations connected with the Word of Faith movement. I am familiar with the Word of Faith movement. I am not familiar with the isolation of older adults who participate in those congregations. So that is something that would be of interest if you wanted to elaborate on what you're mentioning, or if that was just put out there to make note of. But I'm not familiar with older adults being isolated, but I am familiar with the Word of Faith movement.
So Liz,
So that is,
yourself. Liz, could you unmute yourself and elaborate on your question?
Yes, yes. Hi. I was just thinking about people in the Word of Faith movement where they may not feel safe to say, no, I really am having a hard time.
okay.
That
Yes.
they don't have permission to, when things aren't
Yes.
going well, when people go, you're not exercising enough faith, it moves to more and more isolation
Yes.
of the individual, and more likely depression and lack of hope. That's what I'm thinking.
Yes.
And I live in Atlanta, and it is
Yeah.
a gigantic movement across our region, and I'm a healthcare chaplain. So those are big issues in my mind.
So you know what I can say to that? So yes, I would even expand it more, that to all of those who are in traditions, whether it's a cultural tradition, a generational tradition, where strength is promoted. Strength and faith are promoted, and the individual does not feel that they can share their weakness. I think of African American women, older African American women. I think of older Latina women, the matriarchs of their families. And to say, oh, I'm feeling a little blue, I'm feeling sad. How can they say that? I have 4 generations under me depending upon me. If I so yes, in certain faith traditions, yes, definitely. And so we think of zoom out. I call it a zoom out, right? Let's look at that's an issue with a lot of groups where the expectation is not to disclose something less than positive. I don't see mental challenges as a negative. I just see it as things just aren't working like they have been. And so, changing our language and taking and destigmatizing mental health issues and challenges is the first step. And it doesn't mean that God is not with us because I am a little anxious. Like, yes, do not be anxious. The Bible does say, do not be anxious. But the thing about the Bible is it also says that we have a God who is very present in the time of need. And so when we are using spirituality and we're using the language of these sacred texts, we have to make sure that we use all of it. That he is, in our times of weakness, God is made strong. So it didn't say there's an absence of weakness. Jesus said, you will not have trouble, but I'm here with you. And I'm here with you always. And so, I'm not into the, let me beat you up with the Bible when someone shares something when they have, but the Bible says that I have to. Yes, it does. And you just affirm what they say. Yes, it does. It does. What else does the text say in relation to, okay. Oh, I don't know. Well, do you mind if I just, some texts that I've found that have helped me when I am feeling stressed or worried or anxious? Because it's very real. What you're experiencing is very real. And you desire relief. And so that's a whole nother conversation. See, Dr. Cody, you got me started on a whole nother part of my life, the pastor side of my life. But it is, you know, destigmatizing the mental health challenges that our caregivers face is a first step. Validating what they're going through is very important. As a clergy person, as a medical professional, it's very important. And not in a passive way to say, oh, everyone goes through that. No, just it's common. It is something that many individuals are like yourself. So, you know, you're not on the island by yourself in experiencing this.
Exactly.
Just knowing this, that, go ahead. I'm sorry, go ahead. Yeah, I know, we're out of time.
Exactly, Aurelia. We are going to have to end now, but thank
Yes.
you so much for a wonderful presentation and a great discussion that followed. So
Definitely, I love the discussion very much. Thank you, everyone who had a question, who gave me pause for thought. I took my notes to increase and expand on research and knowledge.
okay. Bye-bye, everyone. Thanks for coming, and thank you, Aurelia, again. God
Thank
bless.
you.
Stay safe. Bye-bye.
Bye. Thank you all so much.